Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast. Okay, welcome to the podcast. It's great to see Giles here. And Luke, how are we doing, lads?
Yeah, good, thank you.
Great, man. Good stuff.
Awesome. So today, we are excited to be talking about knees. Knee rehab, knee manual therapy, maybe less manual therapy, more rehab. I don't know, but we'll hear from Giles soon. But yeah, we're going to be diving into one of the most commonly injured and misunderstood joints in the body. Primarily, we're going to be talking about patellofemoral pain, tendinopathy, and meniscus rehab, and then also the integration of manual therapy, when, why, how, and how that fits into the bigger picture of knee recovery. I will start from the outset. We won't have time to cover everything. When it comes to knees, obviously ACLs are huge, fractures, OA, but those types of things we're going to address in a separate podcast because they are big enough to do that. I think in the scope of this one, we're going to lean a little bit more towards the prevalence of injuries that are occurring in athletes or an athletic population, which tend to be a lot of patella pain, a lot of kind of non-specific patella pain that gets lumped into PFP. Then we get a lot of tendinopathy. We have a lot of meniscus problems. And so we're going to kind of touch on those things, especially because a lot of those, there is a lot of movement implementation that helps those types of issues as well. So yeah, knee injuries approximately overall account for around 40% to 41% of all sports related injuries. So it's going to change again depending on the prevalence. So before I get into this, Giles, real quick, how many people off the street are walking into an osteo clinic wanting help for knee issues?
Minimal. To be honest, I reckon osteos and chiros, you're predominantly looking at necks, backs, and lumbers. I honestly think the extremity stuff is a rarity, I see. To be fair, unless you're in that specific condition or you're working with podiatrists or other bits and pieces like that. So I'd say it's maybe 2 out of 10, 3 out of 10 maybe. It's low.
Not a lot. What about you, Luke?
Yeah, I'd probably say probably similar. Maybe a tad higher. I was pretty surprised at how many I were. Like they sort of come in waves, right? You might get like a period where you don't get many, and then all of a sudden, every second person is a knee. So, but yeah, predominantly physios, I'd say.
But I guess you guys out there as well, you've got much of an outdoor living, haven't you? Everyone's more active.
Yeah, there was a period
actually. Us lot sat on the sofas a lot,
where like Brisbane has a lot of half marathon and marathon runs, and even post-COVID and lockdown, like everyone became a runner, and then everyone was coming in with knee issues. So.
And also, they always go heavy, go hard, don't taper up. It's pre-marathon. It's very surprising, actually, how often I see someone come in and I go, oh, so you're going to run the marathon? Yeah. How much training have you done? I just, none. Or I've done a couple of runs. They don't have any idea about tapering, training, increasing the load, and then wonder why afterwards they just like crash. It never surprises me. Prior preparation prevents a piss poor performance, is what I say. So it's all about the prehab.
Yeah, I think it's also the type of activity. Like it's the more common to just get out and pound the pavement and just go for a run without the idea of needing to have a good strategy, not only in necessarily thinking technique, which is something you should think of, but also, like you said, graded exposure, progressive loading, like just these basic principles that we know kind of govern these physiological norms. And so many people, we were talking about this the other day, Luke, so many people are just like, oh, I'm just going to go out, pound the pavement, go for a run. They're going from 0 to 100, and then they have all these knee issues or ankle issues or lower extremity problems. And then when you look at the prevalence rates and you look at some of the research, especially the epidemiological research, we actually see that the incidence of injury in running is actually a lot higher than what you'd see in weightlifting or powerlifting or even some other weightlifting loaded type activities, which most people can't make sense of at first because they think, whenever you add load to any situation, it's going to become more inherently more risky, which is not necessarily true. But I think it's that weekend warrior mindset. And then you also see that sometimes spill over into CrossFit. I know technically on paper, CrossFit has actually quite good numbers as well in terms of injury. It's actually really interesting. So I think running is that kind of, not podcast isn't on running. We should do one on running because Luke's actually don't you have a marathon coming up? Half marathon, is it?
Yeah, half. Yeah.
But yeah, one of the most common things I think that we would have all seen is people come through the door and they're like, oh, my knee is sore. And you okay, point where it's sore. Tell me where it's sore. What's going on? You try to get a history and they'll point to kind of around their kneecap. And obviously there's some testing protocols that we can do. We're not going to go into detail on the diagnostic criteria or how to diagnose these things in this podcast because it's more broad, but there obviously are ways to distinguish between what it could be, but a lot of people just have this kind of general pain, and the pain kind of seems to be exacerbated or it's made worse by kind of general movement as well, climbing stairs, squatting, moving. Sometimes it'll be high, like explosive movement as well, high velocity movements, which is more specific to like a tendon issue, but then it's more diffuse, more of a general pain, less pinpoint. And this is kind of being deemed patellofemoral pain. So shorthand, we call it PFP. PFP is also known as runner's knee, and it affects 1 in 4 people, especially those who, like I said, they run, jump, squat, who are quite active. Really, when we talk about what contributes to it, the best way to frame that is to talk about risk factors rather than sitting here talking about like causative factors, because that's kind of where you get into trouble a lot, being super absolute, saying like this will cause that or this will cause this. And I know especially when we're putting out our content, me and Luke discuss the content that we put out on our social media, we're really actually quite specific and clear about what's a risk factor, which is what could be causative, because you have to be careful about those things when you're trying to educate rehab professionals. Otherwise, they're going to go out there and say to their client, you need to lose weight. That's why you're in pain. When it's like, okay, BMI may be a risk factor, but we can't sit there across the table from a patient and tell them that their knee pain is caused from their obesity if they are obese, if that makes sense. So PFP isn't caused by just one thing, multifactorial, and it has multiple risk factors. And so the main ones that I wanted to kind of put out there would be load tolerance, movement patterns, weakness or poor endurance, BMI, previous injuries, and genetics. And then we are going to see as kind of more common in runners, also single sport athletes. So people that are kind of just doing that one thing and they don't have that variation across the board for that adaptation to those tissue systems. And then also females, but anyone can actually develop it. When it comes to what helps, it's going to be the gold standard, progressive and planned movement, control, strength type training. With this one, there's research that shows that regardless if you're hitting the quads or trying to specifically train the muscles of the knee, or if you're going to do a strategy of above or below, training some of the hip musculature, glute control, strength, that seems to work as well. So keeping them moving, having a plan, and then implementing what we would call like graded exposure. So just making sure that you're bringing them back to movement and loaded movement, but doing it with a plan. You'd remove your provocative factors, and you wouldn't just remove those, but you'd give your patient other strategies on how to move pain-free in the interim. So it doesn't mean you're changing it forever, but just in the interim. And then there is, a little bit of research showing that, hey, taping or shoe inserts as a short-term fix may be helpful, as passive interventions may be helpful as well short-term. I'll follow that on by saying passive treatments may help with short-term pain relief, but obviously active rehab is going to be essential for that long-term recovery. So we often talk about it, and Giles may elaborate, but that neurophysiological short-term adaptation or short-term change, pain perception modulation may be helpful, but it's not going to be the nuts and bolts of the rehab, if that makes sense. Some people will rely more on the taping and more on the potential orthotics, et cetera, and they may have some positive outcomes. But you really have to just consider where the capacity of the person is at. Like if it's a low capacity person and they come in and it's just a niggle, maybe a low value intervention actually would have a high output. It's the same with sometimes when you see people with manual therapy, if they're doing no exercise, their whole life is just like, they don't have anything together, not sleeping well, they're just a hot mess. And then you go and do some manual therapy and they actually have quite a good response to it because they're doing nothing. It's like a little bit goes a long way sometimes. As in if like a super stud comes in, jacked, athlete, they've got everything locked in, man. They're sleeping well, they're doing their supplementation, they're training well. You're like, okay, this dude's, squatting, deadlifting, overhead pressing. How much is my manual therapy really going to have an impact here? That's what I've noticed anyway. So I carry on. Some keys for rehab, just to put out there, just some easy ones to attach to. Like I said, you have to have a plan. I would start small and I would keep it simple. Giles always says it, right? Keep it simple, stupid. You have to be consistent with this type of thing, and you have to use graded exposure. If you go too hard, too soon, or too complicated, you will likely fail. Apply progressive loading. So it's not just exposing yourself to stimuli slowly, but it's progressing it as you're able to adapt to it. And then you have to get them back into the sport that they're wanting to do as well. It's not a gradual return to motion or movement or load, but it's a gradual return to sport as well, right? It's important to say that. And then overall, you want to think about overall health markers, right? Nutrition, sleep, staying active, managing your weight. And then across the journey of your injury, it's being as patient as possible. Does that kind of make sense? So Giles, someone walks into your clinic, they go, "Oh, I've got a bloody sore knee, Giles." And they point, you go, "Where's it sore?" They point to the patella. What are your thoughts on PFP?
What, from a manual therapy perspective?
Of course, yeah, osteopathic manual therapy.
Well, I'm going to crack their OA, obviously. Come on, you're mental. It's obviously an OA imbalance. Something's wonky.
It's the big
Um,
toe. It's definitely the big toe.
it is, yeah. It's the coccyx. It's always the coccyx. You know that. It's my French influence. Look, manual therapy for the knee is a very, very, very small part of a knee rehab process, because research consistently shows, as we say, is exercise and load management is the key for knee treatment. Manual therapy, when used strategically and not just chucked at something, when used strategically as an adjunct to a good rehab plan, can be very useful, especially in the early phases. It can be very, very useful. We know we've got modulation of pain. We can help to try to restore aspects of joint mobility. We can look at sort of addressing sort of muscular tightness affecting movement. We can enhance a variety of aspects in the short term that can help with the exercise rehab, but it is a small part of it. So for me, especially with things like patellofemoral pain issues, yeah, you can mobilize the patella, mobilize the hip, work above and below the area, maintain mobility as much as possible. I've got no issues in MET work towards the glutes and the hips. That's absolutely fine, no problems. And I actually find dry needling very effective for the knee. I really like dry needling, and effectively electroacupuncture as well for the knee. Really good, the endorphins through there, really good vasodilations, all sorts of things that can help temporarily. So you do have lots of different manual therapy options for the knee. It's all about making them feel and move a bit better for a short period of time. If we can get the joints moving, if we can get them walking a bit more effectively, deloading some structures, then it's all beneficial. What I am not advising in any way, shape, or form is to use techniques such as high velocity thrust techniques on the knee. I know we may talk about it on other issues, but one of the big things I see are these big long traction thrusts to the knee or massive lateral gappings to the knee. I just want to ask, why are you doing it? Considering manual therapy is such a short part of knee rehab, what is the point in trying to smash the knee to pieces if we know that it's a very temporary process? So I would say, from a clinical perspective, I'm a massive fan of joint mobilizations. Wobble that knee, move that knee, wobble the hip, ankle, foot, mobilization. As we know for the research, Brogan, we know it's very effective technique, and it can be very effective for the treatment of knee issues. And actually, you can teach your patients to do mobilization work for their hip, knee, foot, and ankle. And I think actively engaging the patient in the treatment process, teaching them some self-rehab, can be massively effective for foot, ankle, knee issues.
This is one of those injuries where some people say, technique or biomechanics, don't matter or whatever. But this is one of those situations where it does quite matter. It's quite important, because really being able to identify what's exacerbating the issue or what's aggravating these factors causing the pain, being able to create a plan where you remove those provocative factors and then give them some new strategies and then just do some basic rehab is going to work a treat at this point. The other things I've found with PFP is that doing some non-specific glute and lower extremity work, quads, hammies, adductors, but even some non-specific stuff actually does work wonders as well. So making sure you're just getting the person moving. If you can identify deficits in motor pattern or movement control, being able to implement that can really work wonders with this. It tends to be someone will come to you and they'll point out, it's sore, this where it's sore, it's sore because of this. Okay, what have you been doing? You're usually able to figure it out pretty fast in the history, and they're usually overloading that structure over and over and over. But one key thing that you're going to want to look out for is that it's not a tendinopathy. And the reason why is because sometimes when you're looking at the history, if they're doing something too often, too much, and too soon, it may present as a tendinopathy. And then you have to differentiate between the two, because you are going to treat those two things differently. So if we are looking at the difference between those two, we are going to have a slight difference in pain location. So PFP is going to be more diffuse around, behind, potentially even just a little bit to the side of the kneecap, as in patella tendinopathy is going to be a lot more sharp, more localized to what we would call the inferior pole. And if it's a quad tendinopathy, it would be the superior pole, right? So that's just above and below the patella. It's also important to understand the differentiation of what's going to make it worse, like the provocative factors. If we're looking at a PFP, it's going to be more like sitting. Often my patients will be like, oh, I've been sitting at my desk and it will start to get sore. At the same time, climbing stairs, squatting, slow loaded movements will hurt it. As in if you got somebody onto the gym floor and then you got them to do something that was like high velocity, high power, sprinting, explosive movements, like tendon loading, which is going to be obviously provocative for tendons, that's where you're going to see a difference. So if you're looking at PFP, it's going to be those stairs, squats, even lack of motion. With the tendinopathy, it's going to be specific to what would be high velocity type movements or explosive movements that are going to aggravate that. The reason why it matters, as I said before, is that we have to distinguish that in the diagnosis because it's going to change the outcome. It's going to change how you treat the patient in front of you, right? So they actually do require different protocols and we don't treat them the same. So with PFP, like we said before, it's quite easy to focus on movement quality, basic load progression, graded exposure, movement control, and just hip and knee strength. And you're going to be, if you know what you're doing, you're going to be okay there. However, with tendinopathy, I think we understand it requires a little bit more of a specific progressive tendon loading type plan, which is all about building resilience within those actual tendon issues. And I'll refer you to the Cook Continuum model for those that want to know a little bit more that maybe don't know about the Cook model. Definitely go check that out. There is a little bit of a self-test that you can do, which is the isometric Spanish squat. And you may be wondering, like, why am I going to get my patient to do a provocative motion like a squat? It's going to hurt them, isn't it? Well, we do know when we look at Ebony Rio's research out of Australia that isometric exercises can provide immediate relief for tendinopathy. Specifically, she actually studied patella tendinopathies. So it's even more specific in this case. I know some people will implement isometrics for other tendinopathies in the body, but it actually is most specific in this case. This test can help guide your rehab approach, but obviously it's not a 100% diagnosis. It's just part of it. But yeah, a Spanish squat, you get your patient to maybe hold it for 30 to 45 seconds. If it's going to feel better after that, that's just a nice little added test or diagnostic criteria that's been fulfilled that it could be tendinopathy. If it feels worse, like you're getting them to the squat and it's like, oh my gosh, they feel terrible after, and there's joint irritation, then it could, be PFP more likely. So there's some good research on that if you want to have a look at that. So in terms of treating PFP, it's, I don't want to say it's fun because I know people are in pain, but it is when people come to see me and they start presenting like this, I start thinking, oh man, this is it's going to be cool to see this person get out of pain. And not only that, but I often say to my clients, like, you're going to have a better single leg squat than me by the time we're finished, because my goal is not only to get them back to where they were, but to get them further and take them beyond where they were and actually strengthen the knees so they don't have these problems in the future and they can go back to what they want to do and do more. And so that's why I always joke about, I'm like, hey, your knees are going to be stronger than mine by the end of it. And I had a client that had some quite significant knee issues. We ended up rolling with a PFP type diagnosis, but we did a lot of strategy work, how to get up off the chair, how to move without pain, and then we did some control work, some hip hinging. We did the progressive stuff, the graded exposure. He was quite a strong dude, but he wanted to get back into lifting heavy, and I sent Luke a video of him. He was like squatting and deadlifting well over 200 kgs. He almost had bulletproof knees at that point. No problems since, just training hard, training like a beast. So we're able to sort that problem out for him long term, and then also give him strategies to be a better version of himself moving forward. And that's what it's all about, isn't it? Any thoughts on PFP, Luke?
Oh, that was great. You covered a lot of it. Like you mentioned, it's just identifying in the history with some of the testing and measures that we didn't quite go into, but the location of symptoms and pain, like you said, it can be quite similar, but when you dive a little bit deeper, it becomes a lot more specific.
Hopefully we're able to give you guys a little bit of our thought process on how we'd treat something like this, because it's never, oh, the knee's sore, let's just treat the knee. Of course, with like a tendon issue, you are going to be treating the knee, but with PFP, you can get away with kind of looking upstream, looking at movement quality, and I know some people will be negative about that and be like, oh, that's ridiculous. Like, just treat the knee. Why are you looking at technique? It doesn't matter. But it does matter when the person coming in is saying that this type of motion is hurting. It does matter when your patient's saying that getting up off the toilet or getting out of the car is hurting. That is when you can start to look into strategies of, okay, hip hinging, how we're going to rotate the pelvis, where we're going to put the load through the body when we are asking this person to get up and down off the sofa, for example, because force is going to be migrated into tissues regardless. We can't stop that, right? It's going to be transferred through the muscle bellies, tendons onto bones, migrated through the body down into the floor. There are strategies of how we can change that. Those forces are not going to be driven straight into the joint that is painful, which in this point would be the knee. So looking into strategies of creating a more hip dominant motion in certain situations can be really beneficial. I know that I've seen that help so many times. So, like you said, we can't cover it all, but it is one of those really, really common. I mean, like I said, up to 23% of adults, 1 in 4, people that are more athletic. So it is quite prevalent. So it's worth talking about and touching on. So yeah, there's a few other conditions that we wanted to touch on, but I thought when it comes to athletic rehab type stuff, it would be interesting to touch on meniscus. I know this is an issue that comes up time and time again. I've had some clients over the years that have had some pretty gnarly MRI results, and they've come to me in a real emotional, vulnerable, quite scared state, to be honest. And whether they've seen another rehab professional or they've actually just come straight from what would be like the MD or their GP, I usually find people coming in with meniscus type issues on like a scan that they're usually quite worried, like they're quite stressed because they've been given this kind of diagnosis of what it is, and this is going to change your life, and you're not going to be able to lift your kids. You're not going. One particular client, who was told you can't do CrossFit, you can't do skiing, and that was the two favorite things that he loved to do. So I'm really interested to hear. You did a great post on a few days ago on our page, Luke. So I'm interested to hear you discuss a little more about the meniscus.
Yeah, sweet. I mean, some of the other knee issues, I'm going to sort of hone in on one topic, which is sort of talking about that post that we did the other week, and it's particularly looking at when sort of surgical intervention is required versus when we're looking at more conservative management. So particularly in the past, I know with family members as well, right, the access to physiotherapy, chiropractic care hasn't been overly that great. So whenever there's pain, they always go to GPs, MDs, get scans, and then that's the process from there. But particularly with meniscus, the research is becoming a lot more evident and clear that non-conservative management can actually be extremely useful in helping someone with this type of issue, particularly if we're looking at the two types of tears. If we're looking at more degenerative, which is going to be more of a gradual process, particularly more age-related, seen in the older elderly population, or we may be looking at a traumatic type tear, which is often sudden, seen in younger people, traumatic during sports, volleyball, cricket, things like that. And that's going to be a massive part of the case history to sort of figure out what pathway and that process the patient is going to be taking moving forward. So usually seen, like from what I've seen as well, they're more acute symptomatic meniscus tears. You're going to be getting that quite sharp pain either on the inner or the lateral part of the knee, on the sort of joint lines there. Potentially you'll get some, locking mechanisms as well, depending on the type of injury. But apart from that, if it's a bit more degenerative, a lot of the time it is asymptomatic. So that's where you'll get the patients coming in with a scan that have previously had a scan, and as Brogan touched on, they're a bit more fearful. They're not sure what's going on. They want a bit more information regarding what's seen on imaging. So particularly with the research, this is where it gets really interesting, and is sort of what I touched on in that post, is with degenerative tears. There's been a lot of studies, particularly one that found 12 weeks of rehab and that sort of type of management had the same quad strength increase as post sort of surgery through there. So just a 3-month stint of some structured progressive rehab came a long way in terms of pain management and symptoms and sort of functional capacity for the patient. A lot of the studies as well have identified that rehab does lead to better long-term outcomes compared with surgery. There's no difference in pain and function between surgery and conservative care. Patient was not inferior to surgery at 2-year follow-up, and early surgery wasn't better than rehab at 24 months. So a lot of what we're getting from this is it is a little bit of a long stint when you're dealing with symptomatic sort of meniscus injuries. It's not an overnight fix. It has to be progressive and structured along a certain time frame. When it comes to imaging, particularly MRI, we're also finding now that a lot of people, when scanning, have some sort of meniscus tear on imaging, even though they may be asymptomatic. So a couple of the studies found that 61% of people with meniscus tears were asymptomatic, and 30% of asymptomatic people had tears on MRI. So I guess the key takeaway for that is a visible tear and sort of structural damage on imaging is not always the source of pain, which is what we've pretty much been touching on as well for the last few episodes on the podcasts when it comes to spinal related complaints too. So when it comes to deciding whether surgery may be necessary or whether the patient is sort of able to go a period of rehab, there'll be a few things that we want to be looking at. So as the patient dealing with a locked knee or mechanical symptoms, that's going to be one of the first things to look at. Are we dealing with a symptomatic buckle handle tear that may require surgical intervention to restore a lot of that range of motion in the knee initially, and then follow up with rehab afterwards? Is the patient young? Are they athletic? Was the tear, did the tear occur through trauma? And is that going to affect the particular sort of vascular zones and things throughout the knee? Another reason we may be looking at is if we've had a period of ongoing rehab, and sort of despite the pain and functional issues, we haven't really gotten anywhere with that. That's where we may need to, put the ego aside and get a second opinion, see what can be done there. So that would be particularly a couple of the main things that we're sort of dealing with. But particularly for me, with the patients I haven't had many very acute ones that have needed to go on to surgery. Most have healed with this type of management, which is a really good thing. So things we're looking to prioritize when it does come to rehab, as I found, there's no real, one size fits all for particular rehab plans. I just start by finding movements and ranges that are pain-free, and get the patient moving within those ranges. So for example, if they can't achieve a full body weight squat, well then I may test a sit to stand to a 90-degree level. And if that's pain-free, then cool, I can throw that in as part of the rehab to improve, hip stability, strength, coordination, things like that. Focusing on progressive loading, as Brogan touched on with the other issues, other knee injuries as well. That's going to be a key. So starting from things that, you may be looking to isolate the quads, the gluteals, the adductors, using isometrics. And then as the rehab plan progresses, you can progress onto things that are a bit more functional, and potentially weight bearing and load. And so basically to sort of wrap that up is, we do have a lot of evidence that rehab should probably be considered as the first modality or pathway for the patient, just depending on whether what sort of symptoms they're presenting with and their sort of history.
So while you're talking, I was just jotting down some notes and trying to remind myself of a few things I wanted to talk about, some things I wanted to address before I throw over and hear a little bit about a manual therapy perspective again from Giles. But I think it's important with the meniscus issue to establish timelines with your patients as well, and to reiterate tissue healing times. We know that the remodeling or the regenerative or the healing process of meniscus tissues and collagen fibers in the body obviously takes time. So sometimes reiterating that is a nice way of saying to the patient, you have to be patient in a sense, because if they've got a big scary diagnosis from a medical professional, they're already going to be on the side of being quite emotional with the whole journey. Sometimes after a few weeks, if things aren't getting better straight away, they may begin to fall back into that thought process of, maybe I'm not going to be able to do these movements for the rest of my life. Maybe I am going to be restricted in my motion. And it can be quite a horrible journey to be on. So reassuring them that, hey, look, conservative care does work when we look at the research. We do have a pretty good understanding of that. We're not just going to address the knee specifically, but we're going to look at the movement patterns and see what this person's doing. So that's case by case. Okay, that's history based. That's also getting your hands on or doing a comprehensive assessment and understanding their movement patterns. Like Luke was saying, sit to stand work or hip work or posterior chain work. It is when these are not sweeping statements. We're saying, hey, look case to case, patient to patient. And then it's also just from the outset, understanding that the meniscus is responsible for a few key things, as we kind of understand the ones that were taught in a university is like shock absorber or stabilizer, distributes weight throughout the knee structures. Like there are some basic things that we learn, and it's important to understand that when you are creating your rehab protocols. One thing that I would bring to everyone's attention is also the proprioceptive information that you're going to be getting to the brain from that structure as well, from the meniscus. So we do have an understanding that there is potential of detection capability from the meniscus of proprioception information from that joint to the brain. And so when you're doing your rehab, that's something else you're going to want to think about with your implementation is proprioceptive training. Now, that's a buzzword because most people, when they do proprioceptive training, they just get people to close their eyes and it's balance work. So we really have to understand the differentiation between how to challenge the balance of someone, which would be like the vestibular, the visual, and the proprioceptive system, versus how are we actually going to challenge someone's spatial awareness or joint position in space, which would be proprioception. Those two things are important. So at the end of the day, conservative care works quite well. It works a treat. There's going to be a time where you're going to have to say, okay, time to refer, and there's a time for surgery. There's a time for other measures. There's even a time for various types of injections and other protocols for people. So it's also being able to say to your patient, these things are not cheating. It's easy as rehab professionals for us to say what we're doing is the right thing. But sometimes as a rehab professional, you actually have to take a step back and make the right decision for your patient. And sometimes that is surgery. Sometimes that is injection. Sometimes that is other medical measures that you may not agree with based on your philosophy, but it's right for the patient. Do you have any further insights, Giles, that you could give to us when it comes to meniscus with manual therapy?
Well, to be fair, I think the key thing here is if you are a manual therapist and you do not have knowledge of structured, strategic exercise rehabilitation, then in order to effectively treat your patient, you have to partner with a rehab professional and work together for the benefit of the patient. This is not a, my magic hands scenario. This is not we can pop it back in, fix it with our fingertips. This is a team, as cliched as it sounds, teamwork makes the dream work. And manual therapy alone is not even going to scratch the surface. It will be at all. And that's why it's important to make sure that you're working with exercise professionals who understand the issue and then can strategically work with you as a collective to get that patient to the finish line.
Yeah, absolutely. And when you've had people come to you that have had these types of issues, do you find that there are some manual therapy interventions where you get more bang for buck? Or do you find that they all kind of follow the same neurophysiological pathways?
They all do, but personally, I find things like electroacupuncture can be really, really effective with joints. You can put it on for a good 10, 15 minutes, really stimulate the area without moving it around too much, without messing it about too much. You can get some really lovely effects through that modality and things like gentle mobilization as well. So for me, electroacupuncture, mobilization are probably the two key ones, and then you can add in your soft tissue bits and pieces as well. But that can be very effective.
Is there ever a time where a high velocity thrust would be appropriate into a knee?
No, and this is the irony. Just because you can crack it doesn't mean you should crack it. And it's common sense. It really is common sense. We always say you think before you click. Don't be thick. Think before you click. And what are you actually doing with that structure? Yeah. Why risk the ligament stability? Why risk it for what is a temporary effect that you can achieve through safer modalities? So in my opinion, I would never manipulate the knee, but then I'm not a one-trick pony.
And if you are hearing the click or the crack, it's not the joint, it'll be the meniscus locking up.
Yeah, you charge them an extra $50. I'll get both.
Exactly. No, that's really helpful. Especially, I think a lot of people listening to the podcast We obviously get a lot of manual therapists listening because you're a part of it, OMT is a part of it, and we post on those platforms. So it's really helpful to hear that perspective, but also hear the rehab perspective from me and Luke, because ultimately it's going to be a process of implementing both. Yeah, rehab is really important. Conservative measures are important, but sometimes the person that's sitting in front of you on that therapist table, that's a real human being that's in a lot of pain. Sometimes for those people that lean all the way towards rehab, sometimes having a skill set of manual therapy can really help
Oh,
short-term
touch
functional,
is so important.
symptomatic.
Therapeutic touch, the reassurance, the connection, the trust, the they're there. When you're a kid, you fell over, your mum rubbed your knee and you felt better. Man, it's a hugely important part of the process, but it's not the whole process.
Mm. Yeah, exactly right. And it's also, you can layer these things. So it's not about doing one, stopping doing the other. It's integration of the two. And if you're not sure, like, what that looks like, I encourage you to continue to listen to our podcast, get into some of our content, check out our social media profiles, our YouTube, even our research, because we're often going over similar themes, aren't we? Like we find ourselves doing different topics, but always converging on very similar themes, because it's what we're passionate about, which is evidence-based practice, in my opinion. So yeah, we'll finish it up there. I'm going to at some point look at ACL, OA, all of that good stuff as well. We try to keep these short, and palatable for those that are listening. So hopefully you got something out of the podcast. Anything from you two lads before we finish up?
No, man, it was good.
No, it was
Thank you.
good. Another good episode.
Another good episode. Go check us out on social media, the Rehab Professionals or OMT Training. Also check us out on anywhere you listen to your podcasts. Apple Podcasts, Spotify, all that good stuff. If you want to watch the podcast, you can check us out on YouTube. If you want to learn more about any of this stuff, you can go to OMT Training. There is so many free courses up there, really comprehensive, really good stuff. Like I said, we're not sitting here trying to sell you anything. There's so much free stuff on that website. Be sure to use the resource. Everyone's always pissing and moaning that they don't have enough resource. There you go. Go to the website, download it. Don't just skip to the end and download the certificate. We can tell when you're doing that. We see you doing that. No, we can't. But it's important to do that stuff. So yeah, go check it out. It's free. It's great. Otherwise, have a great day, guys. Appreciate your time, and we'll see you next week. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast.